speak about the ethical issues of conducting HIV vaccine trials in developing countries and how we actually practically implemented these principles in clinical research that we did in India and in countries across Africa. So I was responsible for the the first ever AIDS vaccine trials that we conducted in India under IRV and multi-country trials that we conducted in Africa. So let's be clear that ethics is the very big picture. Ethics questions, ethics addresses questions about morality, concepts like good and evil, right and wrong, justice, autonomy, beneficence. As J.E. Morse said, goodness is a unique and indefinable quality. We should, of course, always be ethical, but it's probably especially more, when we're dealing with people who are vulnerable or dependent on us, because our not being ethical is going to have a direct impact on them. So ethics is about honesty, truthfulness, fairness, and not about methods of protocol ratification. So as the current status quo inherently ethical with the AIDS epidemic, we're dealing with staggering losses of life, appalling suffering. We've got crippling of society, actually destruction of the whole. We think families are destroyed, and so it's not only affecting the people themselves who are infected, but their whole families, communities are being infected, and we've got millions of orphans, a worsening of gender-based inequities and inequalities. The current interventions are not sustainable. We know that for every one person we put on treatment, we need 4 more people get infected. And by 2015, the ART costs for developing countries alone are projected at $49 billion per year, and universal access is estimated to cost $54 billion per year. And for developing countries like, across Africa and India, these figures are completely unsustainable. So it cannot be ethical to maintain the status quo. A good HIV vaccine has elements of a moral imperative, because even a small reduction in transmission can have a large impact on the epidemic as a whole. Vaccination against HIV could protect those who cannot protect themselves. Example, women. We often see women who are married across developing countries in Africa and India. They can't ask their husbands to use condoms. They often get infected from their husbands. And they don't have the bargaining power. They don't have the financial, economic bargaining power to be able to demand that they can protect themselves. Vulnerable communities like transgenders or men who have sex with men, as well as those who will not protect themselves, example, intravenous drug users. Vaccination avoids a great deal of human suffering, and we know that the only historically proven tool to end viral epidemics are vaccines. HIV vaccine would obviously be a long-term tool to fight the epidemic as part of a comprehensive prevention package. So it would never be used alone. It would be used along with other preventive modalities. And the trials in Thailand, the HIV vaccine trials in Thailand, the results came out recently, have shown that a HIV vaccine is possible. For the first time, we actually found that a vaccine, these were 2 vaccines given in a prime boost regimen, and we found that they were actually efficacious. So now we just have to improve the effectiveness of the vaccine. But up till now, we didn't know. There was a lot of skeptics who said that the HIV vaccine would never be possible. And now we know that it is possible, and it is going to be there in our lifetime, definitely. And the impact of a HIV vaccine, regardless of whether this vaccine would have a low, medium, or high impact, the number of new infections prevented would be significant. So it's not necessary, again, that we wait for this ideal vaccine with 90% efficacy. Regardless of, the first generation vaccine probably will have a low impact, but the number of lives that it will, new infections prevented and the number of lives saved would be significant. But we have to grapple with the ethics of trials, because vaccines and drugs have to be tested in clinical trials, because there are no good animal models, especially for HIV infections. Clinical trials often show unexpected results. And trials in industrialized countries are not always a good guide to developing countries. For example, you're testing a subtype B vaccine in a developed country. I've been involved in trials across Europe and the US with a subtype B vaccine. You cannot extrapolate those results to a subtype C. In India, for example, India and South Africa, the predominant strain is subtype C. So you cannot say that the subtype B vaccine works well in the developed world. So you can't extrapolate those results and say the subtype B vaccine would be able to work in developing countries. So you have to conduct the trials with vaccines which are against the subtype, which are prevalent in the region that you're working in. And trial results in one group might not apply to all groups. For example, a vaccine that is effective in men who have sex with men, where the main route of transmission is sexual, might not have the same impact in intravenous drug users. HIV vaccine trials are sometimes controversial because they involve healthy people in phase 1 trials. And in phase 3 trials, we are working with people at high risk for HIV infection. And these populations are nearly always very vulnerable and very stigmatized. We're talking about populations like transgenders, men who have sex with men, intravenous drug users. And in the developing world, these populations are hugely discriminated and stigmatized against. HIV vaccine trials are very technically difficult. You're actually talking about intimate behavior and social norms. And these are always very controversial topics, especially in really conservative societies like you find in India. So these trials always would require a high level of social involvement, permission, and a thought about the ethics of conducting these trials. Now, just to give you some background on the ethical issues that we constantly grapple with when we were conducting these trials. There's a history of mistrust for clinical research and a history of unethical research in developing countries. So in India, for example, there was unethical research which was conducted with contraceptives, with drugs, and this is when we're talking about unethical. This was hugely unethical. Volunteers did not know what they were being given. There was no informed consent. So we do have a history of unethical research. So that permeates still, and you find that there's a mistrust for clinical research. There's, of course, a stigma associated with HIV/AIDS. The important role of the community and vaccine preparedness activities. When we started the preparations for these trials, we were told that volunteers would not come forward in the Asian and African cultural context. People would be very scared of participating in these trials. They would just not want to come forward. Our biggest fear was that these in phase 1 trials, we were using healthy adult volunteers for these trials. And our biggest fear was that they might be stigmatized or discriminated against. People might think that they're at high risk for infection. And these were people coming forward purely for altruistic reasons. So, we wanted to really ensure that they came to no harm because of their participation in these trials. Need to protect the right and well-being of vulnerable populations. Even the average person in Africa or India, they do not have access to medical insurance. They, God forbid, if they come to any harm because of the participation in the trials, they would have no access to legal recourse. I mean, unless we put in these systems in place, those people actually would suffer from a great deal of harm because of their could suffer from harm because of the participation in the trials. There was a lack of freedom of women to make autonomous decisions due to social, cultural, or economic constraints. And again, we were told that women would never come forward to participate in these trials because they were not free to make their own decisions. And and we actually had to actively address this. We did a lot of gender sensitization training for our staff. We actually put in measures, to address the needs of women and their children, which they often would bring along when they came to participate in these trials. And we found that we had equal number of men and women participating in these trials, which was often not even the case in US or Europe. So it just goes to show that, we started with this whole list of things that everybody said, this just cannot be done. And if you put your mind to it and you work on it, I mean, it is possible to achieve things which, go against the social norms. There's inadequate community and cultural experience with or understanding of scientific research. And insufficient formal experience or capacity to conduct ethical or scientific review of proposed research. So we actually, when we went into the country and we had discussions with the regulatory and ethical bodies, I still remember the first time I went to meet the regulatory body in the country, we were told that there's just no way these trials can be conducted in India because there was no prior precedent for conducting these trials. None of the, everybody knew that these trials were going to get a lot of media attention. So the regulatory and ethical bodies, said they did not want to put themselves on the line, and they did not have the expertise. They said very clearly, we don't have the expertise of, we don't know anything about these vaccines. We don't want to put ourselves in the line by allowing these trials to be conducted. So we actually had to work very closely with these scientific and ethical bodies, develop an actual approval pathway for these trials, and actually build up their knowledge so that they became competent to provide scientific and ethical review. And other organizations after us tried this, but ours was probably the only organization to date which has got permission to conduct these phase 1 trials, novel phase 1 trials in the country. And that's just because of all the background educational and work that we put in, and working with the scientific and regulatory bodies to get them to understand what it was we're trying to do. Trial site capacity and country scientific capacity development was essential. We were very clear that any research that we were doing in the country had to be done to international standards. But we do not even have the centers. We do not have the labs. We do not have immunology or virology labs, or data management centers or clinical centers to physically conduct the trials. And it is very essential to manage the expectations of the community, media, and politicians. For example, if a politician makes one statement against a trial, this has the potential to completely bring that trial to a halt in developing countries. So we actually had to work with a large stakeholder to educate them and make them understand the ethics of the trial that we were trying to do, and get their buy-in before we could conduct these trials in the country. So the core principles of research in developing countries, which I personally have always followed, is when you're working with the community, you need to develop safe, effective, and affordable vaccines against the subtypes of HIV prevalent in the developing world. So we actually developed subtype C vaccines. Subtype C was the predominant strain prevalent in India and South Africa, and tested them in these countries. And similarly, in the other countries that we worked in across Africa, we were actually making sure that the subtype matched with the predominant strain prevalent in the developing country. And for example, the HPV vaccine, there's a lot of media controversy currently in the US about that vaccine. But here's a vaccine for $300. How many people in the developing world can afford to have access to this vaccine? So you have to have safe and effective, but also affordable vaccines so that it actually reaches the population that required. And we made sure that we put in measures to ensure this upfront. Again, fairness. It's the ethical principle of fairness that communities where research is conducted need to have a realistic prospect of rapid access to the vaccine if it works. It's just not ethical that you have researchers dive into a country, conduct the research, take the learnings out, and then the community where the research is conducted does not benefit from that research, does not ever have access to that vaccine. That vaccine might come to that country 10 or 15 years later, and then it still might be at an unaffordable price. So that, at the end of the day, is completely unethical. You need to request the consent and involvement of affected communities. Conduct research in an ethical and transparent manner which is fed back to the community. And it's very imperative that we bring tangible benefits to the communities and countries that host the research. So you need to strengthen the expertise, the capacities, the systems, the infrastructure, the healthcare systems in these countries where we're conducting research. Because what is you could always go into a country, not help them develop any of their capacity, conduct the research, get a team of foreign investigators to go into a country, conduct research, and then take the results and go out. How does the country or the communities benefit from that? And that, at the end of the day, is completely unethical. And when we're dealing with the individuals, so all dealings with volunteers had to be marked by respect for the inherent dignity of every human being. There had to be honesty about the possible risks and benefits. And here, keep in mind that often we were dealing with populations in these countries who had low levels of literacy. They did not even have basic understandings sometimes about HIV AIDS. So we literally were starting from scratch, starting with explaining what HIV AIDS was, explaining what vaccines were, how a potential AIDS vaccine worked, and then going on to explain the details about the trial. And they had to be knowledgeable about the risks and benefits. So we're dealing with populations who do not have a very high level of literacy, but that does not take away from the ethical imperative to make sure that they understand the risks and benefits and can make an informed consent. There had to be a transparency about trial conduct, an agreement about how sensitive data would be handled and protected. Like I said, our biggest fear was that these volunteers might come to some harm, that their personal data would be taken by the media and splashed about. The media would be very happy to, run a story that, see, this is a volunteer who's participating in a trial. But that volunteer then could come to a lot of, and get involved in a media circus and come to a lot of, social and harm. For example, they might suffer from, people might think that they're at high risk for infection, and that's why they're participating in these trials. So, we actually had to make sure that the data was kept completely confidential and there was no potential of their data being leaked out. Full information about care had to be offered and safeguards had to be made available. And there had to be an absence of coercion or unfair inducement. So, and we had to combine this with a realistic estimate of, the choices that poor and vulnerable populations often have to make. So, for example, we could not offer an amount for reimbursement which was very large. You wanted people to come forward for purely altruistic reasons. If you were offering a very large amount as reimbursement for participating in these trials, in these poor communities, people might come forward for the money itself, and that, of course, would not be ethical. That would be unfair inducement. And understanding of all the above had to be demonstrated through independent verification. So it's very well to say, okay, we're going to put in place these ethical measures in our trials. But at the end of the day, you actually have to demonstrate that you've done that. So it's not only in the theory, demonstrate it in the practice by audits and monitoring being conducted. So these were some of the research centers where we conducted these clinical trials: Uganda, Rwanda, Zambia, South Africa, Kenya, and India. So there were 2 centers in India, Pune and Chennai. And this was done by the International AIDS Vaccine Initiative. So I was the medical director responsible for the trials conducted in India and the multi-country trials across Africa. So like I said, it's the ethical imperative to do capacity building in the countries where you're working. You need to leave the countries and communities better off in terms of infrastructure, personnel, technical capacity development, and provide the best possible care and treatment to trial volunteers. And again, I don't think it's an ethical argument that says that, if you're doing research in a developing country, the standards of research can be lower than in the developed world, because even that's not ethical. And even from a scientific perspective, if you're doing research to a lower standard, your data is never going to be accepted by the international regulatory authorities. So then there's no sense in you having conducted this research. So for all these trials, it's not only ethics would not only make sense from a moral perspective, but also it makes good scientific sense. So these vaccine trial centers were actually standardized. So we had the same standard of these centers across Europe, the US, and Africa and Asia. We had the same equipment, staff training, same external quality assurance. Staff was extensively trained, again, as per the capacity building of the teams that we were working with. Infrastructure was literally, we put infrastructure into place. We were working in centers which often did not have even the basic infrastructure. And there we set up clinical centers, safety immunology, virology laboratories, data management centers, and to make sure that the volunteers got the best possible care and treatment. We set up reliable medical reference systems, trial monitoring, offered them voluntary counseling and testing, risk reduction counseling. So it's, and these are measures which were directly going to benefit the volunteers and benefit the communities, because they could be, these centers now are being used for other research that's being conducted in the country. These supporting services that we set up, we train the staff, offer them international, national level training, train them to the highest levels. And now they are able to offer these services even to the other population which access these centers. So it's, it's not only that these measures that we put in place helped the vaccine research, but it also helped the general community, and it's still continuing to do so. We actually prepared informed consent documents which were prepared with expert groups. So we got together ethicists, scientists, policy makers, people affected with HIV, to come and give their inputs into the informed consent documents. They had to be culture and gender sensitive, easy to comprehend, ethically sound. Standard reimbursement is offered so that it would not serve as an inducement. Measures had to be put in place to ensure volunteers' confidentiality. So we actually had very clear-cut language that, what happens, what are the measures that we put in place to ensure the volunteers' confidentiality, and what were the ramifications on the trial team if the volunteers' confidentiality was broken, for example. So that was something we were just not prepared, that these volunteers should come to any harm because of the participation in the trial. All these informed consents were translated into the participants' regional language, so that again, because we were working across so many regions and countries, so we had to have this information translated into the regional language. The volunteers, again, like I said, because we were working with populations who might not have a high literacy rate, so again, they had to demonstrate, we had a test of understanding. They had to score high on these tests of understanding before they could, participate in these trials. So we actually needed to make sure that they understood all the ramifications of, their participating in these trials. And these templates now, they've been adapted for use by other clinical researchers in the country. So the idea is, just to put in place ethical measures and then make sure that they're distributed as widely as possible across the countries. We emphasize the need to obtain informed consent from each individual person rather than from their family members or community elders. And confidentiality, we could not discuss the volunteers' participation with their spouses, family members, or friends, and the decision actually had to be left to the volunteers. There's an interesting story here. Two of the investigators from the centers in India, they thought they were being highly ethical, but their biggest fear was that, if a volunteer's spouse found out they were participating in a trial later on, they might put pressure on the volunteer, and, the volunteer would drop out of the trial. So they didn't want volunteers to drop out of the trials. So they came up with the suggestion that, the information about the volunteers' participation, must be discussed with their spouses and family members, and there had to be buy-in from the spouses or family members before these volunteers could participate in the trials. So, we held a lot of discussions with these investigators and finally convinced them that at the end of the day, it has to be a decision that the volunteer takes whether their information about their participating in the trials is shared with their family members. It could not be a decision that the investigators took on the volunteers' behalf, because that would have been completely unethical. Now, to ensure that the trial volunteers receive the best possible care and treatment for the disease condition during the trial or for possible HIV infection, these volunteers could get infected from HIV due to their at-risk behavior while they were participating in the trials. Care and treatment guidelines for volunteers were formulated through a national consultation. We actually got scientists, community-based organization members, NGOs, people living with HIV, government partners, ethicists around the table. We got in experts from Brazil, South Africa, Kenya to come and share their experiences. And it wasn't an easy task to actually formulate these care and treatment guidelines, because you had to make sure that the volunteers receive the best possible care and treatment, but at the same time it had to be practically implementable. There's no sense in having really guidelines which are not practically implementable, and just having them on paper and not having the volunteers receive the best possible care and treatment. And you cannot again set up systems in a country which are again not sustainable. So it took us a lot of time and a lot of discussions, to actually come to consensus and prepare these care and treatment guidelines. Arbitration boards were set up for the first time for these trials. Medical insurance was offered to volunteers for the first time in the country for the duration of trials. And these guidelines and refined systems were considered as gold standards in the country by the government of India. And these guidelines were actually implemented in trials in Africa and India. And now the interesting, I still remember there was a national level meeting where the government of India invited me to share these guidelines with, and there were representatives of other pharma companies who were there. Because these were considered gold standards, so they wanted us to share these guidelines. And the feedback that we got from these pharma company representatives who were actually conducting trials in the country was that this is all very well, but they were not really interested in putting together such measures. And we provided them with the data that it was actually the cost-benefit analysis, that it wasn't very expensive and it was very practically feasible. And their reaction was, this is very nice, but we are not interested in it. And now recently the government of India has actually put together a policy in place where they're going to make it mandatory for all these measures to be implemented in the country. So it's a very slow process. Now, change does not happen overnight, but if you keep working at it, it is possible to make changes and make things ethically better. And those companies, those pharma companies, actually had that option. They did not. We had done all the groundwork for them. We had put together the measures. They just had to take what we had done and implement it in their trials. And they could have got a lot of mileage out of it. They could have, helped themselves actually, done more ethical trials. But at that point of time, they did not think that ethics was a big enough issue, or they did not think that this was something that they wanted to focus their attention on.
So
yeah, please. I think because they're being recorded, so we can just take questions at the end. And in terms of community outreach, there had to be widespread dissemination of information on clinical research to build support for the trials, to reassure potential volunteers, to ensure transparency about trial conduct. And the communities actually involved in the design, implementation, and distribution of the research results. So we actually engaged the civil society as partners for our HIV vaccine program. We had open door meetings in the high prevalence states where anyone could walk in, and we literally ask any question that they wanted, and we literally walk them through HIV AIDS vaccines, the science behind it, what it was that we were trying to accomplish in these trials. We consulted and interacted with NGOs, community-based organizations, women's organizations, policymakers, donor groups, the media, positive people's groups, lawyers, activists, and religious leaders. And just to give you an example, when we initially started the preparatory work in the country, a lot of the NGO leaders, they were really against the work. They thought that we were using the populations as guinea pigs, and they thought that our population might come to harm. And we actually did a lot of work with them, explained what it was we were trying to do, explained the science of what we were trying to do, explained the ethical measures we were taking. And later on, some of these activists actually turned out to be our biggest supporters. They were so against us in the beginning, and then later they were willing to put their reputation online, write articles, talk to the media, supporting the research that was being done. So it doesn't happen overnight, but it's very important to take the community along with you. We disseminated information on the AIDS vaccine program and the science of vaccines through the newsletter, through the website, info kits, and frequently asked questions prepared on HIV AIDS vaccines, trial organizers, and they were translated into the local regional languages in the different countries that we were working in. We again worked with the policymakers, including the president of the country, prime minister, leader of the opposition, and chief ministers of the high prevalence states across Africa and India that we were working in. We held policy workshops, one-on-one consultations, and regular briefings at both the national and regional level. Again, just to keep them informed about the work that we were trying to do and get their buy-in and get their understanding for the work that we were trying to do. Now the media, this was really a and there were a lot of challenges, but this was probably right up there with. Often we find that in developing countries, the media is the media reporters might not even be scientifically trained. They often do not have a good idea about and they often don't take the effort to confirm facts. They rather have a sensational story which helps their papers sell. And so we literally were starting from scratch to working with the media folks to make them understand the science of vaccines, the complexities and issues about the clinical trials. We held intensive media briefings, one-on-one meetings with journalists and editors. And initially there was a lot of favorable media coverage and community-responsive trials. But at the end of the first phase 1 trial that we conducted in India, there was one reporter who, he didn't even have a basic understanding about the phases of trials or the endpoints or what it was that we were trying to accomplish. And he just wrote a bit story without, any scientific facts. But it was such a sensational story. It was picked up, and we had this whole media circus erupt. And it was, it was really a lot of effort and to, address the media queries, to help address the inaccurate media reports that were coming out and make sure that what was printed actually was scientifically correct. So this led to increased caution regarding media coverage among the partners. But this also emphasized the importance of media advocacy, briefing, prompt response to the queries, a close interaction between global and regional communication teams. And we actually implemented these lessons for future communications, and we had favorable media coverage for other trials that we conducted in Africa and India. So this is just to show you that, you might say that you want to do good, because it's the ethical imperative or something, but it's just not necessary that it's going to be a cakewalk. I mean, it's often very difficult to practically implement the theory, but it's necessary at the end of the day. And it was necessary to have community participation at all levels of the program. So we had a national advisory board, national consultation on care and treatment, a gender advisory group, a NGO working group, informed consent group, a management advisory board. This was just to have buy-in from different stakeholders and different sections of society, and actually make the communities understand, what it was that we were trying to do. These groups had a major advisory role at the initial stage of the program, and there was no prior precedent for setting up such groups. But we felt that it was ethically very important to do so. And our lesson learned was that clear terms of reference and duration of involvement of these members should be laid out when you create these groups. Again, like I said, we did constant advocacy with government partners, public health authorities, key opinion leaders, NGOs, community-based organizations, to explain the constant advocacy, to explain the complex science of the vaccine that we were trying to work on. And we shared the learnings in international consultations across Africa, Asia, Brazil, China, in meetings organized by the Government of India and national and international conferences. And it was very important that other groups who were working globally did not have to reinvent the wheel. We could possibly share some of the learnings of the work that we had done. Because I firmly believe that no one country or one organization is going to be able to tackle this pandemic or develop these vaccines. It's going to require close collaboration between the North and South or South and South countries. Now, in terms of capacity building, when we actually started the work in the country, like I said, we really got a pushback from the regulatory authorities and the ethics committee saying that there was no prior precedent for these trials. They would not give approval for these trials. And so, spent a lot of time explaining the complex science involved in developing vaccines to the national and scientific experts, the clinical research team, the regulatory and ethics committees. We literally started them from scratch. And these are ethics committee members who are often in the late 60s and 70s, have no idea about the global research that's going on around the world. We literally sat them down from scratch and walked them through the various details about AIDS vaccines and the research that's being done globally, and kept them updated so that they could actually provide valid scientific and ethical review. And at the end of the day, we did receive permission to conduct these trials in the country. So it's feasible, but it takes a lot of hard work actually. Now, working with vulnerable communities, just to give you some idea, up till very recently, homosexuality was a criminal offense in India. So you have populations of men who have sex with men and transgender communities. These are populations who are completely stigmatized and discriminated against. They have no access to any kind of housing, food, of course, no job, no medical care. They're completely underground. They live in constant fear that they'll be, that they'll be arrested or harassed by the police. And so, but it was very important and an ethical imperative that we actually work with these populations, because these were the populations who were actually affected by the epidemic, and to get them to understand what it was that we were trying to do. So we held consultations with men who have sex with men, transgender communities, to understand their concerns, access to voluntary counseling, testing, healthcare and treatment services, and gain acceptance by these communities. We did a lot of formative research with these communities to understand their social structure, their risk profile, identify their health-seeking patterns and quality of available services, the potential barriers and opportunities for participating in future, say, phase 3 trials. And it was quite an eye-opener. Here are communities, members who are often infected with HIV themselves. It was they knew that these preventive vaccines would never benefit them directly, but they were still willing to come forward, and help out in this endeavor just because they wanted to help their fellow community members. And these are people who have nothing, little to the name, and to still be able to do so much humanitarianism it was quite unbelievable actually. But the vulnerable communities, we found that they expected the vaccines to be available in the immediate time span, and we found that they had some disappointment when the expectations were not met, and access and retention of these communities may be a challenge for large-scale clinical trials. So in conclusion, we tried to address the ethical issues in these trials, in HIV vaccine trials that we conducted across Africa and India. We set up novel intellectual property agreements, vaccines which were tailored to the subtypes of HIV in the regions of the greatest need, to ensure that the populations actually would have access to the product, if it was found to be successful. Developed long-term relationships and worked in close coordination within the country. Literally, we worked from top down, from the health ministries. We were in partnerships with the governments in a number of countries, down to the local communities. The training of the staff was provided, extensive training, of course, on the scientific aspects, but on the dignity of volunteers, gender sensitization, ethical conduct of trials. And actually, we found, these are actually teams which we often had to put in place no prior experience of clinical research or ethics of trials. But if you gave them enough training and you worked closely enough with them, they did a fantastic job in these trials. We found that we had women enrolled in these trials, in equal numbers as men, which was things that, which were unheard of, and people had said that this would never be possible. We had to be honest about the possible risks and benefits. So we had a complex approval for the informed consent procedures, transparency about the trial conduct by meetings with community, media, advocacy groups. For protecting the sensitive data, we had advice from outside security consultants. We put in the measures for providing care in the trials and antiretroviral therapy for these volunteers in case they became infected due to participation in, they became infected during their participation in the trials. We put in measures for realistic prospects for rapid access to the vaccine if it was found to work. So you actually had agreements that we put in place with the governments of the countries where we were conducting the research. There had to be a flat compensation for work missed and expenses incurred, so there was no unfair inducement. Test of understanding, so we had to actually demonstrate that the volunteers, understood and were actually providing, consent after understanding all the risks and benefits. So, the test of understanding with the high score. We had to, put in place laboratory methods to distinguish between natural HIV infection and vaccine-induced seropositivity. Which is the volunteers might have a positive HIV test, when they receive a vaccine, even though they were not truly infected. But we wanted to make sure that these volunteers came to no harm because of their participation in the trial. So we actually we provided them with special participation cards, for these volunteers who tested positive for antibodies to HIV because of the vaccine. And these are, it was actually worked out very well. We did not find that any of the volunteers suffered from any kind of harm because of the participation in these trials. So ethical behavior requires competent management. Most trial organizers and clinicians will try to be ethical, but some fail to deliver because it's not simple to do what you promised. And any measures that you put in place have to be monitored, measured, quantified, and reported. So not enough to say that we're putting these ethical measures in place without actually having monitoring of trials done and a quantifiable measures being put in place. And ethical behavior is linked to good clinical practice. Like we discussed, poor delivery and bad planning or lack of care would lead to poor retention of volunteers and would render our trial useless. Any inducement, coercion, or failure to explain the risk would lead to dishonesty among our participants and misleading data. Failure to protect the confidentiality of the volunteers, we would have had harm to the participants, and then the other volunteers would have left. So this would have been fatal to the trial. Poor gender balance again would deliver useless results. And so unethical trials would always produce bad results. So it's not only from a moral imperative that you have to make sure that the ethical measures are put in place, but also from a scientific measure. And reasonable people can disagree. I mean, what is the adequate level of care in a clinical trial? Excessive provision might be unfair inducement, inadequate provision might be inequitable. So when does the amount become an inducement? You have 17 visits in a phase 1 trial, and the value of a lost work day is not the same for a lawyer and teacher. So you have to grapple with all these issues. And when is the risk so improbable that it should not be mentioned? Most people would not even take an aspirin if you actually read the full data sheet on possible adverse effects. But at the same time, you have to make sure that the volunteers had a clear understanding of the risks and benefits of participating in the trial and knew what they were getting into. So there's the expertise on these issues, but no monopoly of wisdom. And there should never be a compromise on fundamental ethical issues. But the questions of judgment benefit from consultation. And one unresolved issues remain. We always found that it was very helpful to highlight these to potential volunteers. So a lot of people think about the ethical issues of conducting these research, but we actually had to decide and implement them in the trials. But this is not the end. Folks like you're constantly working and grappling with these issues. There's new thought being given to the ethics, and this is a constantly evolving field. And trials that are going to be conducted, a year or 2 years from now, there might be other measures that I have put in place. But you need to constantly think about these measures and make sure that they are implemented to the best possible in the trials that are conducted. Thank you very much.